can repeat the command now.
So this is 9 years old Jack. Please do abdominal examination.
Okay. Okay, you can start the time now. Good morning. This is Dr. Noor, one of the children's doctor in this hospital. After introducing myself and washing my hands to the Jack and Jack's mother, I will take permission to examine Jack. I will start communicating with him. Is he well communicating, well looking, not in distress?
Yes.
Okay, I want to check his weight, height, and head circumference and plot on the appropriate growth chart for age and sex.
He is on 25th centile for his age, for weight and height.
Okay, then I want to look for any unusual features in his face, like in the form.
No, there is no specific features.
I want to see anything in the surroundings he has brought and any devices he is attached to.
No.
Okay, I will start my examination from the hands to look for pallor, jaundice, clubbing, and also to look for palmar erythema and flapping tremors.
Nothing, only pallor is there.
Pallor, okay. Then I will start checking his pulse and blood pressure.
That is normal.
Okay, then I will look into the axilla since he's 9 years old, any prevertal changes or any lymph nodes in axilla.
No.
No. Okay, then I will examine his face. I will look into the eyes for pallor and jaundice.
There is pallor.
And I will look into the mouth for any ulcerations, oral ulcerations, any central cyanosis, high arched palate.
Nothing is there.
Okay, then I will look into the neck for, I will palpate the neck from behind for any lymph nodes or any swellings.
No.
I will look into the chest for any portacath and central line, and also for gynecomastia and spider nevi.
No, nothing is there.
Okay, then I will start palpating the abdomen. I will warm my hands, make the child comfortably lie down on the bed and start doing the inspection of the abdomen from the foot end and from the sides of the bed to look for the abdominal distension, any scars.
Abdomen is mildly distended.
Okay, position
there
of
is no scars.
No scars. Position
there
of
is no scars. Position is central.
Okay, no dilated veins. I want to check for any dilated veins.
Yes, there are dilated veins.
Around the umbilicus?
Yeah.
Okay, abdomen is slightly distended. Okay, then I will start palpation of the abdomen. I will warm my hands and do superficial palpation, looking for starting from left iliac fossa in an anti-clockwise direction, looking for superficial tenderness and masses.
Yes, there is mass on the right side, right hypochondrium, 3 centimeter below the costal margin.
Right hypochondrium, 3 centimeter.
Below the costal margin.
Okay, now I will start deep palpation.
6 centimeters, sorry, 6 centimeters.
6 centimeters below the costal margin. Okay, then I will start deep palpation. I will go from right iliac fossa upwards to palpate for the liver. Since
how will you confirm that this is liver?
Yeah, I will ask the child to take deep respirations, deep breathing. So I will see whether it is moving with respiration or not. And I cannot go above the swelling. And also it is dull to percussion. So I will check these things and confirm it as liver. And since it is 6 centimeters below the costal margin, I would like to check the liver span. I will start percussing from second intercostal space, coming down till I hear the dullness. Then I will
upper border is in the 5th intercostal space.
Okay, then I will continue to percuss till I hear the resonant sound and mark and check the liver span.
Okay, what else? Next.
Then I will go from right iliac fossa diagonally towards the left hypochondrium to palpate the spleen.
Yeah, spleen is 4 centimeters below the costal margin.
Okay, then I will palpate the kidneys by putting on either side of the umbilicus to see if there is any ballotability and palpable kidneys.
Yes, kidneys are palpable.
Okay, then I would. Okay, I would like to confirm.
How will you confirm? How will you confirm that
Yeah,
these are
I
kidneys?
can get above the swelling and the percussion note will be resonant and they are ballotable. Okay, once
You cannot get above it, huh?
I can
Or
get
you
above
can.
the swelling. Okay, then
Okay,
after
good.
that I will do the percussion. So I will, since the abdomen is mildly distended, I will consider to do shifting dullness. I will start percussing from below the Ziphy sternum coming down till I hear the dullness. Then I will go laterally till I hear dullness. Then I will ask the child to, if I hear, to move
There
around.
is dullness.
Okay, then I
Shifting dullness is there.
ask, okay, there is shifting dullness. Then I will consider to auscultate the vowel sounds and also renal bruit and liver bruit.
Okay, that's normal. What else you want to
Then
do
I
in
will
order
ask
to
him, the
complete?
child to sit down. I will ask the child to sit down
Time finish.
to look, okay, to look back for any
Okay.
scars and pedal edema.
Okay, there is no edema at the
Okay, in
moment.
order to complete my examination, I want to look into the hernial orifices. I want to take detailed history and examine vital signs and do the hernial, check the hernial orifices, genital area, per rectal examination and perianal examination and lymph nodes
Okay,
examination.
present your case.
So today I examined Jack. He is a 10 years old boy, presented with presenting with, he is well communicating, well looking, and on 25th centile for he has, on my examination of his abdominal system, he has pallor only, no jaundice, and there is hepatomegaly 7 centimeters below the costal margin and splenomegaly 6 centimeters below the costal margin, and also there is renomegaly.
Okay, so what is your impression?
So this may be a case of glycogen storage. This may be a case of storage disorders, most probably glycogen storage disease.
Why there is splenomegaly? Think again. I will give you again. You did not focus on which I have given you finding. He is paler. He is having hepatomegaly, which was 6 centimeter below the costal margin, and splenomegaly, which was 4 centimeter below the costal margin. There is shifting dullness is there. So that is meaning ascites is there.
Portal
There was
hypertension.
veins around the umbilicus. That is caput medusa. So what is this case?
This may be a case of portal hypertension.
Very good. So what may be the cause of portal hypertension, particular in this case?
Hepatomegaly, splenomegaly, and renomegaly.
And there is nephromegaly also, bilateral.
Maybe portal vein thrombosis.
Why portal vein thrombosis, Dr. Noor? This is a very simple case. I will tell you, okay, but after that. Okay. So I will ask you detail. I will tell you. So I will ask you what is the causes of differential diagnosis of portal hypertension or causes of portal hypertension?
Yeah, portal
Tell me.
hypertension are divided into prehepatic,
Yes.
hepatic, and post-hepatic.
So what is the cause of prehepatic?
Prehepatic usually portal vein thrombosis or obstruction or any cause which causes obstruction.
And hepatic, intrahepatic.
Usually cirrhosis of liver, any cause causing cirrhosis of liver.
Okay, cirrhosis, fibrosis, biliary atresia, neonatal hepatitis, alpha-1 and actually intrahepatic always divide into pre-sinusoidal, sinusoidal, post-sinusoidal. Pre-sinusoidal there will be some kind of mass. There can be any malignancy, there can be any cyst, or there can be schistosomiasis. Okay, and sinusoidal, it is particular. Sinusoidal is required for there are cells. Sinusoidal means there are cells. So that will be leading to the cirrhosis. So cirrhosis will be there, any cause of cirrhosis. There can be fibrosis, there can be alpha-1 antitrypsin deficiency, there can be of cells are there, so maybe inflammation means hepatitis or neonatal hepatitis. There can be of from there these biles are exiting, so there can be biliary atresia. So sinusoidal, to remember, there are cells. So cells can be fibrosed, cells can be cirrhosed. So there can be congenital hepatic fibrosis, there can be any cause that leads to the cirrhosis, there can be biliary atresia, there can be neonatal hepatitis, there can be alpha-1 antitrypsin deficiency. Then is coming post sinusoidal. So post sinusoidal is, from post sinusoidal, what is the structure? Veins are coming out, so veins can be occluded, can be obstructive. So this will be veno-occlusive disease. Veno-occlusive disease, that will be hepatic vein outflow tract obstruction.
Okay,
Okay.
hepatic vein obstruction, yes.
Then is coming post-hepatic. Post-hepatic, what may be the causes? Only three causes which we have to remember.
Congestive cardiac failure.
Very good.
And Budd-Chiari syndrome.
Yeah, Budd-Chiari
and
syndrome.
pericarditis.
Yeah, constrictive pericarditis. Okay. So let's say we will come to conclusion, no problem. So what may be the symptoms of portal hypertension?
Portal hypertension will have splenomegaly, raised portal pressure, and
Just
this
to
portus
memorize,
emissions,
you will not forget.
emissions.
I will tell you, there
Okay.
are mnemonic, very easy mnemonic. Then you will never ever forget. Either remember A, B, C, D, E, or either remember varices. Varices, we know, everyone. Esophageal varices, there is important hypertension. So just memorize varices. V is for variceal bleeding. A
Okay.
is for ascites. Then is coming R. R is for renal impairment. Then is coming I. I is for iron deficiency will be there. Then is coming C. C is for caput medusa or congestive gastropathy, which we all know, this variceal bleeding from there, congestive gastropathy. E is coming for encephalopathy, or S is coming for splenomegaly. So varices is the main symptoms of portal hypertension. How will you remember? Just memorize. V for variceal bleeding,
Variceal.
A ascites, R is renal impairment, I is iron deficiency, C is caput medusae or congestive gastropathy, E is encephalopathy, or S is splenomegaly. Again, I will tell you in A, B, C, D, E. If you want to remember like this: A for ascites, B for bleeding diathesis, C for caput medusa or congestive gastropathy, D for diminished liver, E for enlarged liver, enlarged spleen, sorry. Like this, if you want to remember. But this is difficult. D for diminished, we can forget. E for enlarged spleen, we can forget. Varices is easy. So
Yes.
these are the symptoms.
Okay.
Okay. Then now I will ask you question. What was asked in the exam, recent exam? It was in UK. This came two times, not one time. This came two times, and 2019 third time, also in Jeddah, 2019. So so let's say this is a portal hypertension, and the child present with you with variceal bleeding. So how will you manage?
Yeah.
So just think.
I will check the airway, breathing, circulation, check the vital sign,
Okay.
involve my consultant, and then I will
Okay.
give the IV fluid bolus 20 ml per kg. I will reserve the blood grouping and cross matching, and call the blood bank for the blood, urgent blood. And then I will involve the gastroenterologist to consider for endoscopy, so that we can do the sclerotherapy or ligation. Other thing is, I can also consider to give octreotide, which is a splanchnic vasoconstrictor.
Octreotide or vasopressin also can be given.
Mm.
And what else you will
Also,
you will do?
and also I will consider to give IV omeprazole. Because
Okay,
of
IV
bleeding.
meprazole you can give. What else? This is portal hypertension. So just I have told you,
Hmm.
E is encephalopathy. So what will you do for encephalopathy?
Yeah, if there is the encephalopathy, I will consider reduced protein diet and
Okay.
lactulose. Oral lactulose can be given.
So start like this always.
Ammonia, reduce.
Yeah, prevent the accumulation of ammonia. Sorry. For that, you will identify the precipitating factors. Then you can improve the liver function by reducing the protein intake. And you can use this lactulose, and you can use antibiotics. Which antibiotic we are using here?
Neomycin.
Very good. So there
Neomycin
can
is
be
given
of
oral here in the, it's written oral. Is it? It is given oral or what?
yeah, orally they are given.
Okay.
Orally they are giving. So bacteria, even in the recent studies, they have enter flagell also. But this is, I think, American study, not in UK. So don't forget.
Okay.
Hepatic, this is bacterial peritonitis, one of the
Subacute.
complication of ascites that can lead to the bacterial peritonitis. For that, always educate uh, parents, educate the nurse for the hygienic proper and early detection and treatment with appropriate antibiotics. So bacterial peritonitis is usually due to streptococcus, this I think streptococcus or staphylococcus. So for that, you will have to start antibiotic also. So whenever they will ask you, you have started very nicely. I will start airway. If I will check for the airway, breathing, circulation, and then I will check for the vitals. He is stable dynamically or not. According to that, if he's not stable dynamically, I would like to stable him by giving the crystalloid. I will maintain IV line with two large bore cannula.
Two large bore
Okay,
needles.
two large bore cannula, and send the lab test and for the cross matching.
Blood grouping and cross matching.
Cross matching involve my consultant and gastroenterologist as well. So the treatment, further treatment क्या है हमारी, what is the treatment? So we will have to start like octreotide, we can start vasopressin, sclerotherapy, or variceal ligation. That will be depends upon gastroenterologist. Then these childs, as there is ascites, so they are prone to develop bacterial peritonitis. We will have to educate the staff nurse, we have to educate the parents and carers, and to early detection, and to give the appropriate antibiotic treatment if child needs. So there is associations are hepatic encephalopathy. So my goal is to reduce the accumulation of ammonia and increase the functions of the liver. So for that, I will advise to reduce the intake of protein, and use of proper can start antibiotics like neomycin, and prevent the constipation. So for that, lactulose can be added.
Hmm.
Okay, then there can be of, I told you, impair renal. Uh, I is for impairment. R is for renal impairment. So renal impairment. Then if there is renal impairment is there, we called it hepatorenal syndrome or hepatorenal failure. So this is a terminal stage. For that, only the treatment is transplant, liver transplant.
Hmm.
Okay.
Hmm.
Okay. One more question. So I want to. Sorry, Dr. Yasser, I'm taking too much time today. I just want to finish this topic so
Okay,
that
no
if
problem.
we ever we will listen this, so this will be far better for to understand. What may be the complications of cirrhosis?
Complications of cirrhosis is again portal hypertension.
Again, very good. So if there is portal hypertension, numerate all these. Like there can be portal hypertension, there can be bleeding diathesis, there can be
Hepatic
susceptibility to
encephalopathy.
infections, ascites. Okay, then
Infection.
there can be yeah, infections, encephalopathy can be there. or
Hepatorenal.
impaired, because cirrhosis is there, so functions of the liver is impaired. So functions of the liver is impaired, so hormonal metabolism or any drugs is we are taking, metabolism that will be impaired also. Okay, so that can all leads to the impairment of the neurodevelopment. Definitely all metabolism is impaired, so neurodevelopment impaired will be there. So other malnutrition will be there definitely. So other things which can also be involved: hepatorenal syndrome, hepatopulmonary or pulmonary hypertension, which we called pulmonary hypertension can be there. And there can be hepatorenal syndrome, that will lead to the renal failure. There can be of gallstone formation, because this metabolism is not going properly. There will be definitely endocrine changes will be there. And again there, yeah, these are the things which we should memorize. So how to memorize, this one complication cirrhosis is hepatoma also. It can lead to the malignancy. So how to memorize, they can ask you, this question was asked in the exam. So just to memorize this one also, how, whenever they ask you complications of the cirrhosis, so just to memorize, cirrhosis can leads to the pulmonary hypertension. So all, whenever you will think of pulmonary hypertension, there is pneumonic varices. So memorize all varices: variceal bleeding, ascites, renal impairment, iron deficiency or malnutrition you can consider there. And C for congestive gastropathy, venous impairment, this caput medusae, E for encephalopathy, and S for splenomegaly. Splenomegaly can be or cannot be in cirrhosis, because cirrhosis, splenomegaly is particular for the portal hypertension, not for the liver. Okay, just remember. One question now I will ask you: what may be the causes of cirrhosis?
Yes, causes of
This is easy
cirrhosis.
for you.
Yeah, causes of cirrhosis can be metabolic causes
Yes, very good. So
like
what are the metabolic?
Wilson's disease, alpha
Very
1
good.
antitrypsin deficiency, tyrosinemia,
Yes,
hereditary fructose intolerance, uh,
yes, glycogen storage.
fibrosis, cystic fibrosis.
Yes, very good. So
Okay.
sis, just to yeah, okay, that's good. Okay,
Uh,
what other? What other?
1 minute, I forgot. Just wait, I'll tell you. Infections.
Yes, infections can
Infection.
be there. What kind of infections? Hepatitis B, C,
See,
cytomegalovirus. So what others?
and this means intrahepatic and extrahepatic biliary obstruction.
Yes, this is which I want to
First, this is the
yeah,
first
learn from
intrahepatic.
you. This should be the first.
First,
Why
yeah.
this should be the
That's what
first?
I suddenly forgot. I am not getting the points. Extrahepatic.
Yeah, these all were rare.
Yeah.
Wilson, glycogen, alpha 1 antitrypsin, these all were rare causes. Mainly think of in the child is biliary atresia, first number one. Even in the post Kasai procedure, that can lead to failure of the Kasai procedure
Yeah.
and can lead to the cirrhosis also. So this is the first, biliary atresia. Then is uh, choledochal cyst. This is all extrahepatic. Congenital hepatic fibrosis, this is intrahepatic. Cystic fibrosis, this is intrahepatic. Sclerosing cholangitis, again this is I think extrahepatic. So these are the causes. Others infections: hepatitis B, C, cytomegalo, or any other infections. Sometimes drugs, especially adult, especially alcohol takers, they have this. And nutritions like TPN, if they have used TPN, they can lead to the cholestasis, and they can lead to the again cirrhosis also.
Yeah.
So these are the,
For intrahepatic, I think the commonest cause is Alagille syndrome, right?
yes, intrahepatic allergy syndrome.
Yeah.
Okay, now I will before coming to your, just to memorize
I
for
did
the
not
portal hypertension.
understand in your case, you said hepatomegaly, splenomegaly, and also renomegaly. Why there was renomegaly?
I'm coming to this one.
Okay, this
I'm
confused
coming.
me actually. Then I got, when I was presenting, I forgot about this ascites totally, and I was confused why there is hepatomegaly, splenomegaly, and also renomegaly. Then
I will come to that point. Just two things left. Then I will come to your case. So always remember, in if the child is having portal hypertension, we have concluded that there will be varices, which we have studied already. So
mm,
if the child is not having no clinical problems is there, no biochemical features of liver disease also not there, liver is also not enlarged, but you have found that signs of portal hypertension, which you know, and there is splenomegaly
so then I will
only.
consider portal vein thrombosis here. I will consider
Yes,
portal vein.
because liver is not enlarged, so there is no pathology in the liver, and this is not the backflow that is coming to the liver and liver will be enlarged. No. So if there is no biochemical features of liver disease, no clinical features of liver disease, and there is no liver enlarged also,
Hmm.
yani liver is completely spare, but only there is splenomegaly and signs of portal hypertension you have found, you will directly say this is maybe due to portal vein obstruction, that may be due to portal vein thrombosis or some congenital problems that leading to the portal vein obstruction, or there can be anomaly of the portal veins, or there can be of some procedure has been done in the neonatal period like umbilical catheterization that leads to the portal vein thrombosis, or there is some abdominal sepsis was there that leads to the portal vein thrombosis. So these are the causes. Then if this is the one scenario in portal hypertension, then is coming, you have found that signs of portal hypertension is there, which you know.
Hmm.
Then you have found liver is large also,
And tender.
but there is no stigmata of liver or liver disease is not there. Stigmata of liver disease. You have found only liver is large, but there is no stigmata of liver disease. You have found portal hypertension, signs of portal hypertension, and liver is large. So then you will think of what is our case,
Hepatic.
congenital hepatic fibrosis.
Hmm.
This is our case. Okay. In congenital hepatic fibrosis, 75% cases, this can be associated with large polycystic kidney disease bilaterally.
Hmm.
Okay.
Hmm. Okay.
Just they can bring this case came in, I think, before in Jeddah, but in UK there was, they have not given this nephromegaly, they have not given, they
Mm-hmm.
have given only this hepatomegaly and splenomegaly only. So they have not given, because on 75%
But
cases
I
there can be.
missed one point here. When you said the liver enlargement, I should also see for the consistency of the liver in congenital hepatic fibrosis.
Yeah, I'm coming to your case, which you have forget in description, not description, examination. When I told you there is liver, how will you know this is liver? You have told nicely. Then you will say, I would like to check the surface of the liver, edges of the liver, and what else? Contour of the liver. Okay, this is
Consistency.
very important. Consistency, contour,
Surface, border,
uh,
consistency.
the border, surfaces. You will,
Size, shape, no need, because we will know the liver shape, and also we
yeah,
will
yes,
we already measured the size. So, and
yes,
the liver span. So I should comment on the surface, border, consistency, and also on the tenderness. I have to comment whether it is tender.
yes. You should say that. I would like, as I have found there is liver is palpable. So I would like to know about the shape, about the surface, about the border, about the tenderness, all this consistency, all this. Again, this is for the spleen as well.
Mm,
Okay.
mm.
So they will not give you any these finding, but that will be for the purpose of exam purpose. This will be a good idea to ask. So then just I will tell you one more thing. if there is liver is small, that what means? Yeah,
Cirrhosis.
cirrhosis. So cirrhosis can lead to the portal hypertension.
Mm.
And liver is normal size.
Mm.
Liver is normal size. Maybe you have palpate 1 centimeter or 2 centimeter. That is normal. Okay.
Portal vein
And
thrombosis.
again, you have found portal hypertension. This will be pulmonary, portal
Portal
vein
thrombosis.
obstruction. And if you have found anytime liver is enlarged and there is portal hypertension, this will be congenital hepatic fibrosis.
Mm.
Okay, this is one thing.
Okay.
Also remember that always we are saying that cirrhosis liver is small, but not in cystic fibrosis. In cystic fibrosis, cirrhosis can be there, but liver can be large.
Cystic
Why?
fibrosis and congenital hepatic fibrosis, both these
Yeah, these two
they have
things,
large liver.
large liver can be there. So just to memorize this one also. And what else we have left here? Yes, nothing. Just hypersplenism is there, that can be if
Yes. Due
it's
to
coming in the,
splenomegaly, there can be
this can be thrombocytopenia, anemia, or leukopenia can be there. Just to memorize it. And mainly portal hypertension causes is always remember, this can be first leading cause is portal vein obstruction or portal vein thrombosis. Again, this can be due to liver problem. In the liver can be either cirrhosis or either fibrosis, congenital hepatic fibrosis, or any thing that is leading to the cirrhosis, or this can be due to hepatic vein outflow obstruction, that is post sinusoidal. Okay, just don't think of post hepatic Budd Chiari, right ventricular failure, constrictive pericarditis. They are not bringing this one. This is very rare cases. So all these we have differential diagnosis cirrhosis we have done. And yes, one more thing I just want to tell, that there can be a case of you have found no, I will not. I will give you next day, today, tomorrow, or day after tomorrow. I will not tell. Okay.
Okay.
Halas. I want to give you this case because this came in 2018.
Okay.
Okay. Halas.
So next, let's go to Dr. Yasser. Then we will come back to it.
No, I will give you one more thing.
Hmm.
I have prepared for you one history.
History. Okay. Now you will give, or we will finish first one case with Dr. Yasser.
Okay. Dr.
You
Yasser,
are
yes.
free, or you have anything?
No. I'm free today.
Okay.
I have slept too much. Alhamdulillah.
Okay, good. I have some doubts also, which we will discuss in the last. Okay. Not about this case. Some
Just
other.
close the recording.
Huh? Okay.
Intrahepatic portosystemic shunt.
Okay, trans intrahepatic portosystemic
Portosystemic shunt. This is tips. And before they were using also Blackmore tube or something. All these now old things. Now they have vanished it. Now they are. I think they are doing directly sclerotherapy, or second what is ligation, or the at the end tips they are going for tips. This is trans intrahepatic portosystemic shunting. This is portosystemic shunt, simple name, or tips.
What they do in this exactly?
I don't know. They are
actually
bypass.
they connect this portal vein with hepatic vein, so they bypass the portal vein flow to the systemic flow.
Yeah, they are bypassing the liver actually. This is just a bypass.
But
okay,
you know, by
the hepatic vein directly to the portal vein.
Just like this, they are doing such maneuver. There are different type of tips. Wallah, it's very big topic.
Okay.
Yeah, I don't.
So should we mention
think so. They will ask you.
or no?
Mention.
Yeah, you should mention.
Okay, as means after all this, first is sclerotherapy, then ligation. After
First is bending. band ligation, we call it bending, then sclerotherapy. First of all, we are doing this one medication. If not improving, we put Sangsticken. If not improving, we can go for this sclerotherapy, bending and ligation. If not improving, go for sclerotherapy. If not improving, go for tips. And if not improving, go for liver transplantation.
I think Dr. Yasser, they removed this one Sangsticken Blackmore tube.
Well, I will check it again, but I see
Okay,
in the
no
figure
problem.
it's written.
Now what is given is Mark he has given sclerotherapy and ligation only. These two only is given there.
Yeah, from sclerotherapy.
And
Randomly they have written.
Consideration of splanchnic vasoconstrictors like octreotide.
Octreotide, yeah, vasopressin.
They are all given IV,
No,
right?
sorry. They are using sandostatin.
What is sandostatin now?
Sandostatin they are using in this variceal bleeding also, which I remember.
No,
when
but this means this octreotide, I think it's given IV, right?
The brand name of octreotide is sandostatin.
Brand name is
Okay.
which I remember. We are writing Sando always. Why? When I was working in this liver unit.
Okay.
Okay.
So vasopressin and octreotide, same action.
Yeah.
There is one thing about terlipressin. The same, they are doing the same work. Octreotides and this terlipressin, both are same.
Okay, we can go to the next case.
Okay. Next case, Doctor
will give,
Yasser will give to you.
Okay, can I give my case?
Yeah, give.
Yeah, you have to discuss with Shifa, medical student, regarding this neck.
Necrotizing enterocolitis.
Okay, you will give me 2 minutes. Okay. Once I am ready, we will start. Okay, I think we can start now. Who will keep the time? Dr. Adnan, you will keep
I will keep the time.
minutes and 3 minutes. Okay. So
when you're ready, start.
Shifa, right? Shifa, medical student. Okay.
Yes.
Good morning. Hi, Shifa. How are you?
Dr. Yasser, open your mic. Yasser is there.
Hello.
Yeah, sorry. yeah.
Start now. Start again.
Good morning.
Good morning.
Shifa, how are you?
Yeah, I'm fine.
Okay. This is Dr. Noor today with you. So how are you doing in our unit?
I'm fine, Dr. Noor.
Okay, so I got to know that today you have to discuss about some topic with me today. So before that, I want to ask, do you want any of your colleagues to attend this session with you?
No, doctor. I'm fine.
Okay, welcome. So can you tell me what you want to discuss today? What's your topic of discussion today?
As you know, doctor, we had a round in the morning and we saw two patients in the morning. Both having necrotizing enterocolitis, and one of them have surgery. So I want to know about this necrotizing enterocolitis. What is this one?
So I appreciate your keen interest in the small babies and you're trying to learn. You're a very good student. So let's start now. Let's make this discussion means let's make this discussion an interactive session. Is that all right with you?
Yeah.
Okay, so necrotizing enterocolitis, what do you know about it? Anytime did you read about this condition?
Yeah, doctor, I know that this is the inflammation of the bowel, something just like I know up to this one, and I know.
Yeah, very good. So let's go like this. See, the necrotizing enterocolitis, it is there in the word itself, means enterocolitis. As you know, it is the inflammation of the small bowel and the large bowel both. Okay. Necrotizing means sometimes this will get necrotized. That means the tissue in these bowels can die. Okay, this is what it means. So do you know which babies are more affected and any risk factors for this?
Yeah, we know. I know this premature. I think so. They are more prone to this
Yes,
disease.
very good. Yes, premature babies, they are more prone for this. Any other risk factors, you know?
I think we are giving more blood to those patients, but I
Yes.
don't know more any.
Okay, so yeah, premature babies are more prone, and also we should be careful about, along with that, these babies will also have other problems, like they will be on ventilators, and we will be frequently drawing the blood, and they will also be on, they may not take the feeds, they may not take oral feeds, and they may be on total parenteral nutrition. Okay, lots of problems with these small babies. So tell me what else you want to know about necrotizing enterocolitis.
I want to know okay, why it happens in small children.
Yeah, actually, the exact cause is unknown. The predisposing factor here, as I told you, is the prematurity is the predisposing factor, and also they may not feed well. The breastfeeding, they may be on the ventilators. Okay, so what exactly happens in this condition is there will be inflammation of the bowel and the tummy becomes too big. Have you noticed in one of our children like this?
Yeah. We have.
Yeah, their tummy become too big, and also you can see the dilated veins here in the tummy. Okay. So can you tell me about what investigations we do for these patients?
I think we do CBC X-ray. I think so.
Yes, very good. Anything else? Okay, no problem. Yes, CBC we do. Maybe they may have some pallor, or they may show the signs of infection. You know, inflammation here is due to infection as well. So there may be raised WBCs, you can see, and also you have, along with that, you should also send CRP and blood cultures. These babies will be very unstable sometimes, you know, due to infection. So you have to send CRP and blood culture, and start immediately, consider immediately antibiotics. You have to do the septic workup, including the urine analysis. Okay, and main thing, you will keep them nil per orally, means nothing will be given. So you will insert the NG tube into their tummy, and also you will consider, so they are not eating and you are emptying their tummy. So what do you give them?
We can give them this TPN. I think so, as you told before.
Yeah, and also sometimes IV fluids also. Before considering TPN, you will be starting them with simple crystalloid fluids. Then if this condition is prolonging, you can consider total parenteral nutrition. Okay.
Doctor, how can accept these things? How can we treat the patients?
Yes, very good question. Actually, to start with, as I told you, this babies may be very unstable. So we will monitor airway, breathing, and circulation. That means vital signs has to be monitored. Capillary refill time has to be monitored. And if they are dehydrated, we will start them with the IV fluids, and we will put the NG tube. All these things will be done. And since they will be serious, you will involve your consultant. Okay. Anything else you can tell me?
Yeah,
6
I
minutes.
want to know. Okay. I want to know how can we prevent this one?
Yes, actually, sometimes early starting of breastfeeding can help, but nothing is clear, no thing is clear to tell that in premature babies you can prevent, because they have multiple problems. Okay. So can you tell me about still what else management we can do apart from the basic management in these children? Do we go for surgery in all children?
I think so. No, we don't go to. We can follow by alas X-ray
Yes,
and
very good. So X-ray findings, do you know what will be the X-ray findings in these children? Okay, no problem. They can have, sometimes these children can have perforation in the bowel. So you can see sometimes air under diaphragm. And when you do the X-ray, there can be, already you see the distended abdomen, there can be too much dilated bowel loops. Okay. Can be seen. And sometimes also in the layers of the intestine, you can see the air. Okay. We call it as pneumointestinalis. All these things you can find, but I want to also tell you some important management points. If you know, you can tell me.
no, I think you tell the sufficient one. So
Yeah, okay. So in the management, what else we do is, apart from after stabilizing the baby, as I told you, IV antibiotics play very important role, and you will observe the baby as a medical management. That means keeping nilper orally, admitting the baby in the NICU, and observing if there is no perforation, and if there is no pneumointestinalis, and if there are features of necrosis, to consider for surgery. So early surgical involvement works here. Do you have any other concerns about necrotizing enterocolitis?
no, doctor. Thank you.
Time, what is the time?
Half minute left.
Did you tell at 6 minutes?
Yes.
Yeah. He
I
told.
cannot concentrate, sorry. Okay, so I will summarize to you. Today we discussed about two babies in our unit who is having necrotizing enterocolitis, and how to manage these babies, how to treat and manage these babies. What I will do you, I have some good notes about this. I will give you, you can review it, and also you can go through some trusted websites. I will give you the link.
Time over.
And how do you think about considering a seminar, doing a seminar next week about necrotizing enterocolitis?
Okay. Thank you.
Okay, thank you so much. I don't I don't know, I was not remembering some of the points, because without revision suddenly we do. I just give your feedback, Dr. Yasir.
Yeah, it was good. The same. We all have a problem because we have a too much knowledge, and we that's the issue. Um, the other is thing, just like we have to. There are three factors involved here. That is hypoxic ischemia to the gut wall. Second is bacterial colonization, and third is enteral feeding. These are the three main pathophysiology for this enterocolitis. So just remember this one. Huh?
Enteral feeding means starting early breastfeeding through the.
Yeah. Which any type of feeding. It's better we can start. Sorry, hyper. Ideally, we have to start this express breastfeeding most of the time because they are premature and unable to suck. So we have to start. But mostly this is hyperosmolar. This milk. Breastfeeding is is the you can say is a preventive prophylaxis thing is there.
Yeah,
Preventive.
breastfeeding is okay, but other type of enteral feeding will be the cause here.
Yeah.
The bottle feeding. And other thing is the hypoxic ischemic injury to the bowel and bacterial colonization.
Yeah. These
So
three things.
regarding the investigations and management, do you want to tell anything?
That's are okay. Any CBC is septic profile, electrolytes, because there is hyponatremia, thrombocytopenia, metabolic acidosis, and chest X-ray. We are following by serial chest X-ray. And indication of surgery, these are the one.
Abdominal
nematosis.
chest X-ray.
Yeah,
Abdominal X-ray.
yeah.
You said chest X-ray. Okay.
Sorry, abdominal X-ray.
Real abdominal X-ray to see these two things. One is the air under the diaphragm and pneumointestinalis, right?
Yeah. Yeah.
The
These two
indication
things.
for surgery is perforation, one thing, and also necrosis.
Yeah. These two things are the main thing. And other regarding how can we prevent them? Early breastfeeding, probiotics, and third thing is this feeding techniques.
Okay, feeding techniques means?
Well, I don't know. It was written in Khidr. So
Actually, actually here you will have to tell that sometimes there can be not only just premature babies. So sometimes mother have some problems, like if the mother's during this bleeding is there during pregnancy, or mother is having high blood pressure or diabetes mellitus. All these are the factors. So how we can prevent proper during pregnancy, proper management for the mother, so mother will not develop these complications. For that, proper follow-up for the screening. Okay, these are the things. And also if there is early introduction of cow milk, that should be prevent. Don't give the early introduction of cow milk. Rather encourage the mother milk breastfeeding, I mean. So these will help to prevent. And also the early infection if the child is premature, so proper hygienic measures, this will also help to prevent
Okay, the
from
cause is three things. What about the other factors? The child is on the ventilator and all these things.
you can say
yeah these
congenital heart disease, polycythemia, blood transfusion, and
yeah these all are the factors which are
contributing factor.
contributing factor which can lead polycythemia, congenital heart disease, or if any mother has used some drugs, or mother is having some complication during pregnancy, like uh, this is eclampsia, preeclampsia, or umbilical catheterization. All these are the factors which can lead to the necrotizing enterocolitis. So if we will carefully monitor the child and carefully monitor the mothers during pregnancy, these can be prevent from happening.
Congenital heart disease most commonly here will be this patent ductus arteriosus in small babies.
Yeah.
Okay. So now we will go to next. I have to read now, I think, NEC from the neonatal guidelines.
Yeah, or either neonatal or a check leaflet is there. Leaflet is very good to study for these communications, I think so.
Yeah.
Okay, I will give you no case. So this is 13 years old Kathleen, and she is complaint of loss of weight, headache, and tiredness, lethargy from last 3 months. So please take focus history and give your management plan.
Okay, 1 minute, wait. 13 years old Kathleen complains of loss of weight is the main complaint, and also headache, tiredness, lethargy from 3 months.
Yeah, more than 3 months.
Okay, so take history and give your management plan. Okay, I mean, you will set the time now. You can start 3.5 minutes from now. Okay.
Okay.
Okay, once I'm ready, I'll tell you. I think we can start.
Okay.
So you will keep the time now.
I will keep the time. Maybe one call will come. Just wait. If call will come, I will interrupt for 3-4 minutes only.
Okay, no problem. At that time, you can tell, and Dr. Yasser will pass the time. Where is Dr. Yasser? He's not there.
I don't know.
Okay, anyways, I
Maybe
will
some
keep.
call.
No, let me do one thing.
No, I will keep the time. I will keep the time.
I will also keep the time. If you go, I will pause the time.
Yeah.
Okay.
Okay. Okay.
Okay. Start. I am starting now. Okay. Good morning.
Oh, just 1 minute. 1 minute. I want to tell. You are talking to mother of Kathleen. Mother name is
Mother or
Jessica.
13 years old
No,
Kathleen?
no, no. You will talk to mother.
Mother of Kathleen. Okay. What is her name?
Jessica.
Okay. Mother of Kathleen, Jessica. I am talking. Kathleen is 13 years old. Okay.
Yes. Yes.
Okay. You can start the time now. So,
Start.
good morning. This is Dr. Noor, one of the children's doctor in this hospital. Am I with Jessica, the mother of Kathleen?
Yes, doctor. I'm Jessica, mother of Kathleen.
Thank you for coming here and nice to meet you.
Thank you, doctor. Welcome.
Today, I am here to talk to you about Kathleen's health condition, and I will take some notes. Is that okay to you?
Yes, doctor.
Okay. Can you tell me what is your concern about Kathleen's health at the moment?
Well, doctor. Just 1 minute. 1
Okay,
minute.
no problem. No problem. I'll pause. Okay. Good morning. This is Dr. Noor, one of the child and
Good morning,
adolescent
doctor.
doctor. Am I with Jessica, the mother of Kathleen?
Yes, doctor. I'm Jessica, mother of Kathleen.
Thank you for coming here and nice to meet you, Jessica.
Thank you, doctor.
Today I am here to take some notes about your child Kathleen's condition. Is that okay for you?
Yes, doctor. I'm also worried about her. So
Yeah,
that's fine.
from the GP letter, I got to know that you're facing that she has some weight loss, she feels tired, she has some headache. Can you
Yes,
tell
doctor.
me more about her present health condition?
Yeah, well, doctor, almost before I didn't notice that, but last from almost more than 3 months now, I'm I'm seeing that she's losing weight, and sometimes she's feeling headache also, and all the time she's in her room. So these all things, and sometimes she's saying that I'm feeling tired, and sometimes little bit active. So I don't know what's going on. So before I was thinking maybe this child's like at her age, so maybe some there
Okay.
is no issue. But now from 3 months, so that's why I
Before
was
three
concerned.
months, she was fine. Before 3 months, she was okay. She was good.
Well, doctor, I will not say that she was okay, but I will say that yeah, from last 1 year, I am seeing her. She's behaving like differently.
Okay. Can you tell me more about the weight loss? Are you measuring her weight?
Well, doctor, I'm not measuring, but which I have feel that now she's wearing her clothes, and that is loose.
Loose. Okay. But there is no measurement in any time you
No,
did.
no, 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 doctor. I did not measure, and even I did not follow any GP, or because I was not considering it seriously. But now more than 3 months, so I went to GP and he
You told me
referred to
she
me.
has some behavioral changes. Can you tell me about it?
Well, doctor, not like that. I mean to say, behavioral changes. Yeah, yeah. She's spending all the time alone in her room, and she's very fond of this music. And sometimes I have listened that she's listening this music very big voice, high pitch voice, and all these things. So
Okay.
these are the,
I want to ask you, does she feels that, does she has a feeling that she is overweight and she want to reduce weight? Is she expressing such feelings to you?
well, yeah, doctor, you can say that. Sometimes she's saying that I'm little fat, so I don't want to eat mama these things. So like this.
Anything,
Yeah.
anytime she's doing vomiting because she don't want to eat, or she's hiding food and she said, I am eating, anything like this?
Well, doctor, I did not notice this one.
Mm,
Maybe sometimes she's throwing out by
mm.
herself. Sometimes, maybe, I think so.
Any medications she is using? You have seen her using any medications? Like
Well, no,
laxative,
doctor. Yeah,
laxative,
sometimes. For what medicines? I'm not getting you.
like to make the pass poo, what we call it as laxatives.
Yeah, yeah. Sometimes I have seen in her room, she was using this bottle. There was written lactulose,
Oh,
and she was using that one also. Yeah.
okay. Can you tell me more about her headache? Headache.
Yeah, doctor, headache is not all the time, I will say,
Hmm.
but it's not increasing as well. And this is, I have noticed that from the last 3 months, sometimes she is complaining, I'm feeling headache, so please don't disturb me. I want to take rest. And she's going to her room and she's sleeping there.
Any
So,
change
yeah,
in the vision? Any change in the vision and hearing?
well, no, doctor, that is not.
Any no
Yeah.
change in vision and hearing. Okay. Headache, does she complains that it increases while lying down, or any difference in the headache?
No, no, no.
Anything she's using to really reduce the headache, like medications?
No, doctor, she's not using. Maybe sometimes paracetamol only.
Okay. Anytime did you go to any doctor and any investigations done?
No, doctor, I did not go.
Okay. Regarding her eating, do you feel that she's not eating well in the last 3 months?
Yeah, doctor, she's a little bit now choosy about eating. Before she was not like this. From last 1 year, I'm noticing she's a little bit
What
choosy.
choosy means? What is she preferring to eat?
Yeah, doctor, she's don't like junk foods. She's using sometimes soup only, like this. Yeah.
Okay. So I want to ask you some more questions. Tell me if it is there or not. Like, does she has, you told me already about headache, any abnormal movements anytime?
No, doctor, there was
No.
no abnormal
Okay.
movement.
Any jaundice in the eyes, or any yellowish discoloration of the eyes or anything?
No.
Any ulcers in the mouth?
Well, no, doctor, I did not notice. But sometimes there is bad smelling is coming from her mouth.
Okay. Any shortness of breath? You feel she's short of breath?
No, doctor.
Awareness of heartbeat?
No.
Any fever?
No, doctor. She did not
Tummy?
get anything.
Anytime tummy ache, vomiting, diarrhea, any complaints of the tummy?
No, doctor.
Her pee is fine.
Yes, she's fine.
Pee. And poo, what
Yeah.
about poo? Any complaints of her poo?
I don't know, doctor. Maybe she's having some constipation because she's using this lactulose.
But you don't know. Okay. Any complaints of the joint pains she's doing?
Yeah, sometimes she's feeling tired, and sometimes she's saying that I'm feeling pain in my joints, but not all the time.
Okay. Any skin spots you're seeing, or darkening of the skin or skin spots?
No, doctor. I did not notice that one.
No. Okay. She's now 13 years old. Any changes in her, like she's big growing up, maturity, any breast growth or any hair growth in the axilla?
Yes, doctor. She got her puberty at the age of about before 12 years also, and from but last from almost 2 months, she did not pass any her period.
Okay, so does she has last 2 months no periods? Okay.
Yeah.
Okay. Okay, can you tell me about any she's feeling any too much of hot or too much of cold, any feeling like that?
No, doctor.
Okay, so now I want to ask you about the anything when she was small, any complaints she had, like past in the past she has any problems, anytime
No,
admitted to the hospital?
no, doctor. She was not admitted to the
She
hospital.
is a healthy baby with growing well like her peers.
Yeah. She was completely healthy.
Okay, can you tell me about your pregnancy?
Yeah, that was completely fine, and she was delivered at term, and she was about 9 pound, I think I remember. Yeah,
Okay, she was crying well.
yeah. She cried at birth, and the same day we were at home and we are celebrating.
Okay,
Yeah.
no problems. Huh? Has she taken her shots complete?
Yes, doctor, completely.
Okay. Can you tell me about your family?
Well, doctor, I have another child, John. He's 8 years old. He's completely fine,
Mm.
and my husband and we are relative, and my husband is lawyer,
Mm.
and I'm housewife.
Okay. Any family history of medical problems like diabetes or anything, some diseases like celiac disease, like any family history of problems?
No, doctor, but my mother, she was having celiac disease, I remember. No, you told me, so I just remember.
Okay. Any other diseases, like thyroid problems or anything in the family?
No.
No. Okay. Can you tell me about how is this condition impacting you and also Kathleen?
Well, doctor, I'm quite worried because all the time she's with me. I'm at home, so she's not behaving like before. So I was thinking maybe something is in her brain, maybe, or that's why it is very worrisome for me. And she's all spending her time separately in the room all the time. So this is, yeah,
Okay. I'm
difficult.
sorry for that. We
And
will.
for her also, yeah, and for her also, yeah, doctor, I don't know, she's not telling us what, how she's coping with this, or what she's thinking by herself, or what's going in her mind.
Okay. Can you tell me about her school? Is she attending the school regularly or any school absence and also performance in the school?
Yeah, performance is okay. Yeah, that's fine. And
Absence?
she's attending the school, and she's also uh, going to this rugby classes. She's fond of rugby also.
No bullying at school or anything?
No, well, doctor, there is nothing like this.
Okay. I will about her activity. You already told that she stays alone and separate.
Yeah,
Um,
doctor, this is a little bit, yeah, different
she's
now.
going out with the friends sometimes to eat outside.
Sorry, I forget to tell. 10 minutes it's past. There is
No
left
problem. No
only
problem.
1.5 minute.
No
Sorry.
problem. Is
Yes,
she
yes.
activity is good?
Yeah, doctor. Nowadays, she's active. Yeah, that's okay.
No,
But
no.
she's
She's going
sometimes tired.
outside
But
with the
she's active.
friends. Outside with the friends to eat outside.
I don't know. She's spending much of her time in the room, but sometimes she's also going outside with her friends, and they are enjoying parties, each and everything. Yeah, doctor.
I will ask you some personal questions about her. If you feel comfortable, you can answer me. Otherwise, it's okay.
Yes,
Is she,
yes.
have you noticed any time she's smoking or taking alcohol or any drugs or anything?
Well, doctor, no, doctor, I did not notice that. Maybe she's sometimes smoking because one of her friend is smoking also. So I am thinking so, but I don't know exactly.
She has any relationship with anyone? Do you think like that?
Yes, there is her boyfriend is there. Yeah, I know.
Okay. Anytime she expresses a feeling to you that she doesn't want to leave anymore, like this, any depression, any expression?
No, no, doctor, she did not tell me like this.
Okay, I want to ask you, anything you feel that is important about her, you want to tell me?
No, doctor, I don't think so. Yeah, that's okay. Time over.
Okay.
Present your case.
Today I took history from Jessica, the mother of Kathleen, a 13 years old girl. Her main complaint was loss of weight, headache, and feeling lethargic from 3 months. Mother has not measured the weight. It is she has always it's subjective that her clothes have become loose, and also she has not followed up with any GP or any physician, and no investigations are done regarding it. She has a feeling of that she is fat and she want to reduce her weight, and also she was using laxatives as noticed by the mother, and she avoids to eat junk food. She prefers to eat drink soups like that, and she has no intolerance to cold. She has no any skin pigmentations, and also uh, so her birth history was unremarkable. Her past medical history is also unremarkable, developing well like the peers, and vaccinations are up to date. And there in the family history, the grandmother has celiac disease, and social history, it is impacting the mother. Mother is worried about her condition. And socially, she goes out with the friends. Sometimes she smokes. She might smoke, and also she has a boyfriend, and she has no suicidal tendencies, and she is attending school regularly.
Okay, so what is your impression?
With these findings,
Impression?
this is a case of weight loss uh, in a teenager for differential diagnosis. My most probable diagnosis is anorexia nervosa.
What
Uh,
else?
and others, I want to rule out other conditions like hyperthyroidism, celiac disease, any tumors, any tumors she may have, or even the Addison's disease. However, I nothing supported me in the history for these conditions apart from anorexia nervosa.
Okay, so what is actually anorexia nervosa?
Anorexia nervosa is the feeling of being fat, and the child will take less calories than the expenditure, and their BMI will be less than 80% than their mean BMI for age.
Okay, so what investigation would you like to do?
Yes, in this patient, I want to do CBC, urea electrolytes, electrolytes mainly, including phosphate, magnesium, and calcium. And
What
also, I want to
what
do
you tell? Repeat just one more time.
electrolytes, including
Okay,
phosphate, magnesium, and calcium.
okay.
Okay,
What
and
else?
I want to do liver function tests. And also to rule out since there is family history of celiac disease, I want to consider celiac screen in this child.
Okay, what else?
And I want to take the weight, height, plot her BMI on the chart.
Okay, this is the first thing which you have to tell that. Okay, we will come to that. Okay, so what may how will you recognize how will you manage this child?
Yeah, for the management of this child, first I will check the airway, breathing, circulation, and her vital signs, because sometimes if there is long term starvation, they can have hypotension, and also they can have bradycardia and arrhythmias. So
Mm.
I will check airway, breathing, circulation, vitals, and stabilize the child, involve my consultant. And slowly I have to start the IV fluids for her, and also introduce refeeding for her.
So refeeding, there is a refeeding complications. What may be
Yes,
that?
yeah, refeeding complications is they may have reduced potassium. They can may have after starvation. If we restart refeeding, there are chances of potassium depletion in the body. So we need to replace the potassium. Sorry, not
What?
potassium, phosphate.
Okay. Yeah.
So we have to measure repeated, monitor phosphate, and if needed, phosphate replacement has to be given in these children. And also blood pressure has to be monitored and replaced with the IV fluids. And arrhythmias, ECG has to be done to monitor the arrhythmias.
Okay. So further, what will your management? IV fluid
Further, I
you are
want to
given.
consider a multidisciplinary team involvement here. I will involve the management of Mrcpch group, management of really sick patients with anorexia nervosa, which involves a team of doctors, including the pediatrician, the nurse, the psychiatrist, and a dietitian. So they will give her a dietary advice, how to have a good health with a good weight. And also a psychiatrist will counsel her to overcome this eating disorder. And also the pediatrician will follow her the weight and also the routine problems with them. And the nurse will.
What you tell Doctor? No, this Marsipan group. What is this?
Mrcpch group. Okay, let's finish your this, then I will tell you. Okay.
Okay.
Any question? Any more
No,
questions?
no, no. I have finished. I will come to my that. Tell me, Marsipan.
Mrcpch group is this is a group which is in what really sick patients. Mrcpch, right? Really sick patients with anorexia nervosa. Okay,
Tell, tell,
this is a group
tell
in
me the
UK.
spelling.
Management,
Spelling. Tell me.
MAR, management of really sick patients with anorexia nervosa. This is Mrcpch. Okay. But I don't know, I read yesterday, but most of the points I forgot.
Just you yesterday read, huh?
I read yesterday in anorexia nervosa. Today I forgot most of the points. Refeeding syndrome I remembered, but I don't know what I left really.
From where you this one written,
New
Marsipan?
new pediatric guidelines. I will show you now, so that we can.
Okay.
We can just revise investigations and management. It's not too much. It's
Okay.
very less.
I will
You
now
just
I will
give
tell
your
you.
this till I open
Yeah.
the
Yeah,
guide.
you open and I will give you the feedback. You were initially presenting complaint. You asked me and systemic in sorry HOPI was good. History of presenting illness was good. Then you asked me systemic inquiry. There is Dr. Noor. I will tell you as you are now the candidate. So ask complete questions. Don't just go for systemic inquiry as you are not. You are just show that you are thinking of for the differential. You are
Mm.
not just fulfilling systemic inquiry. Sometimes we are just fulfilling where we are fulfilling where we know the exactly the chronic disease and now presented again. So there we are just fulfilling systemic inquiry. He's having this a heart problem. He's having this one shortness of breath. He's having CNS problem or not. No, here this was the case, was acute case or chronic case, but that was not known before. So this is newly
Acute
diagnosed.
case. This is newly diagnosed.
Yeah, newly diagnosed. So for here you will have to rule out what may be in your mind for the differential of losing of weight and headache and lethargy. So
Hmm.
what will be in your mind? Like you have asked each and everything, but incomplete sentences was very much there.
Like just
Like
can
first,
you just tell me how to do it?
yeah, yeah, I will tell you. When you have asked about presenting complaint and history of presenting illness, then you should start your differential. First differential is regarding this can be inflammatory bowel disease or celiac disease. So complete your sentence there. So how her bowel habit nowadays? So would you like to tell me more about her poo? Would you like to tell me about her bowel habit? So do you think that she's having either anytime she's having constipation or having anytime loose poo, she's having tummy pain or her tummy is increasing in size? Is there any difficult to flush the poo?
This
Is
I
there
will ask
any
in the HOPI only or in the systemic review.
systemic? This will be in the systemic. This
Okay,
will be in the
this
systemic.
will be in systemic, but I should ask, I should give some time and ask properly.
Yeah, yeah, you should ask properly each and everything. Is there any do you think is there any blisters in her mouth or soreness in her mouth or soreness in the back passage? So this will you cover the celiac disease, you have covered the inflammatory bowel disease, you have covered the irritable bowel syndrome. These three things you have covered now.
Mm.
Okay, also the any malignancy in the abdomen you have covered. Then come to the if you want to ask thyroid, again check, do you think that she's having any neck swelling or any difficulty intolerance to cold? Because this is hyperthyroid will be here, not hypo, because losing weight is there. So intolerance to cold is there or not? No,
Intolerance to
not
heat.
sorry, intolerance to heat. Intolerance to heat is there or not?
Mm.
And she's feeling any heart is racing. So this will cover your hyperthyroid. Then come to the SOL, space occupying lesion or any mass. So anytime you know that she's having throwing out sorry, early morning throwing out episodes, headache, or she's as she's now losing the weight, so she's feeling any night sweats or bone pains. So this will cover your all malignancies and as well. Then come to your diabetes in the for the diabetes mellitus, you asked me just is there any any concern regarding the P? I don't have any concern. But if you will ask me, do you think that she is
Mm.
peeing more
Okay,
before,
I
or
got you.
she's feeling more thirsty before? So this will give the idea to the examiner that you are asking particular for the diabetes mellitus. If you will ask about do you have any concern regarding the P, so okay, I'm just a student and I'm studying with you, I can understand you are asking me about diabetes mellitus. But examiner will think that no, you are asking generally, maybe she's having some problem in the P or not. No, this will be not a good way. If you will ask that if you have any problem being more, or she is more thirsty, do you think that? So examiner will get idea, yeah, this doctor is ruling out diabetes mellitus, that is good.
Mm.
So
Okay.
like this
Mm.
complete sentence will help you, which clearly and complete sentence that I am ruling out diabetes mellitus, I am ruling out hyperthyroidism, I am ruling out inflammatory bowel disease, I am ruling out celiac disease. Then you ask me about any dark pigmentation, that was very nice. Then ask about if she got any time dizziness or fainting episodes before. Clearly I know these all things were in your mind and you have asked me, but this one I was understanding because we are studying mutually. We can understand you, you can understand me, what we are asking. But examiner will not understand you. They want to, listen that you are asking clear questions or not. for your rule out differential.
Okay, my
So
rule
for
out,
that,
after HOPI,
yeah,
after HOPI, my rule out differential will be mainly in systemic review.
yeah, this will be systemic review.
For that.
Yeah, this is your complete systemic review, and you are rolling out your differential. You will ask that is any time do you think that Kathleen got loss of consciousness or fainting episodes? She got any pigmented mark or dark mark on the skin or any time bruise? Do you think that? So yeah, now you will complete your systemic inquiry. So you have asked about the diabetes mellitus, you asked about the Addison disease, shortness of breath, you asked about the cystic fibrosis, inflammatory hyperthyroidism, and celiac disease. So now you have complete your presenting complaint HOPI and this systemic inquiry where you have rule out. Then there will be three questions. Behavior, I have told you myself, and you have very nicely asked about the depression, suicidal attack. Two things more you should ask, which I think very much, because she's having also a boyfriend. So physical abuse or any sexual abuse anytime in the past or any recently. Okay, this one is very important here because she's now separating herself. So this may be obsessive compulsive disorder can be there. So you should, this one also came in the exam, but it was very old. So you should ask about the physical abuse or sexual abuse, or yeah, these two things, or any trauma admission you have asked me. Very nicely you have asked me about the laxative use. Very nicely you have asked me about the uh, she's wearing about the clothes, and she's feeling herself fat. There are questionnaires that is called SCOF, SCOFF, SCOF questionnaires.
Okay.
One is S is sick. You have asked me. That is very nice. I know so many people don't know about this SCOF questionnaires. That is particular for the anorexia nervosa. S is for sickness. So you asked me, is she is anytime feeling sick after eating and she's throwing out this? So this is called S. Then is coming the C is control. So this one you should ask, she's anytime lost her control about eating, because this anorexia nervosa sometimes they are eating too much, but they will throw out food.
Yeah.
Sometimes they are not eating. So you will have to ask about the anytime you think that she has lost over food, lost of control over food. So control is C. Then is coming O is 1 stone loss of weight in 3 month period. If they have lost 1 stone, it means this is more than 6.35 kg weight. Okay, then you ask me about she's anytime she's thinking that I'm fat, this is coming F, fat. Then you ask me about the food. uh, would you say that food dominates your life, like this? Do you think that food is dominates her life all the time? She is thinking about the food. So this is another eating disorder. So this is the SCOF questionnaire. You asked about three ones, only you forget two. Then here was the diet history. Diet history should be asked a little bit more because you have too much time. I was saying on the time, and you have too much time, you can ask each and everything. That is very nice. You time management was very good. So you can ask about the diet history complete. You ask me about food, what kind of food she is eating, and ask how many times in a day she is eating. And then I said myself that she is this junk food she is not loving. And you asked me about the lactulose, that is very good. Sickness about very good. And type of food you asked me about very good. Any dieting plan, and how many times she's eating in a day. Two these things, then diet history will be okay. Otherwise was completely fine. Then I will come to the management plan. You have given very nicely each and everything. uh, I never ever study from this book, red book, or I don't know. For the labs which I know, I don't know from where I did study this one labs. We are doing CBC, ESR to check for any anemia or any infections, and then we inflammation also. Then we will go for serum electrolytes, LFTs, RFTs. Bone profile is very important here. Bone profile all will be calcium, magnesium, as you have told, and parathyroid hormone level, vitamin D level, B12 level, folic acid level, albumin level, and micronutrients like zinc and selenium. And we are doing for DEXA scan. ECG is very important here. Chest X-ray sometimes required, sometimes not required, and serum amylase, celiac screen. So these all will cover your malnutrition, all will cover your inflammatory
Differential diagnosis.
and associations. Okay, and serum electrolytes and all these you told. So then coming to your management. So for the management, very rightly you said that I will start with the take after taking the history, I will do the examination. Then I would like to take the vitals, and if it's vitally stable or not, I would like to check for the airway, breathing, and circulation. And after stabilizing, I would like to involve the my sorry this consultant. So would like to assess her physical health, physical effects of malnutrition, and any compensatory behavior, like if she's throwing out any, and if how much she required mental health services. I would like to check this one, all these things. So for that,
Also,
which
we
I
have to monitor her, means she may conceal the food, she may wear
yeah, yeah.
heavy cloths. All these things has to be monitored also during the treatment. I forgot, I read, I read and I forgot really. I don't know. I will show you the marzipan here and also the treatment. What you said, everything is here in the red book. Just 1 minute only. So this is under the heading eating disorders. Okay.
so few things. Then we will study. Just 1 minute.
Yeah.
You should tell about the psychological treatment was very important here, which you did not tell.
I told
So
no.
no, you
The
just
psychiatrist I told.
yeah, psychiatrist you told, but give your plan also.
Okay,
Like psychological treatment here is focused family therapy, anorexia nervosa. This is called FTAN.
Okay.
Focused family therapy, anorexia nervosa, where we are doing the sessions with the family or alone with the child. And these sessions will be almost 18 to 20 sessions over a year. Okay. Then other family members will be involved, and other families, that can be group study. This group involvement will be there.
Support groups.
Yeah, sport group type. Then if it is failed or contraindicated, or any time child is not involving or family is not willing to do that, then you will go for cognitive behavioral therapy with the eating disorder. This is called CBT-ED. Okay.
Now everything is combined with this marzipan. This is what I know now.
Yeah, okay. I don't know about this marzipan. Adolescent focused psychotherapy, anorexia nervosa. This is another term. Okay, in the monitoring, what we are monitoring, we will not only monitoring the weight, we will monitoring the blood pressure. We will monitor the relevant blood test which we have done already. We will monitor her arrhythmias for ECG. We will do, and we will do the discussion of the treatment options with the family also. This is all we should tell. And the multidisciplinary team, you forget about endocrinologist, very important here.
Okay, endocrinologist for this periods.
Not only for periods, this is irregularities of these all in the bones, and this
Osteoporosis.
minerals. Yeah, these all regarding they are dealing endocrinologists. So their team will be pediatrician, endocrinologist, psychologist, psychiatrist. These are the team with the medical. Then will be then is coming, yeah, then is coming paramedical. Paramedical is dietitian or nutritionist. Then will come occupational therapist as well. Then will come rehabilitation therapist, and you will have to involve the nurse, mental health nurse specialist, and dentist, and GP, and community pediatrician as well.
Okay, CAMHAMS will also come here.
Yeah, CAMHAMS,
Okay.
child and adolescent mental health services. So now you can study. Otherwise, that was good. But I want that we should tell each and everything, that so that we can take complete.
Yeah. See here in the investigations, I forgot. Yeah, as you said, I made myself. I categorized these investigations into different things. Like I put CBC, urea electrolytes together, like urea electrolytes, phosphate, magnesium, calcium. All these we have to do, very important. And liver function test, thyroid function tests, and glucose. Okay. Then, as you said, amylase and bicarbonate, and we have to do vitamins here, very important. Vitamin D, vitamin B12, folate,
Ferritin level.
and also here zinc level is very important. This I categorize in vitamin. ESR, CRP, I think mostly to rule out this IBD, maybe, right?
Yes.
This is for to rule out. And celiac screen to rule out celiac disease. Ferritin maybe as acute phase reactant. And also they may have low iron. Okay.
Yes.
And as you, this osteoporosis, vitamin D. I forgot all these things. I read but yesterday. Okay. Then management, this refeeding syndrome, we have to be aware. Apart from that, overactivity, concealment of food, they may conceal the food, interfering with nasogastric tubes, vomiting and laxative use, manipulating weight, wearing heavy clothes, concealing weights, drinking water. And this Mrcpch is in next page. Discuss with local specialist CAMHAMS eating disorder team. So here we have to involve the childhood, adolescent, and mental health service. In that also there is eating disorder team. You have to involve them, local. Then aim to build a specialist management of really sick patients with anorexia nervosa. This is Mrcpch group. In your multidisciplinary team, you will involve this group. Okay. Management of really sick patients with anorexia nervosa. This includes who, psychiatrist, nurse, dietitian, and pediatrician. And you will follow the Mrcpch guidance. Okay. So early recognition and treatment of anorexia nervosa improves outcome. This is what I was telling, but there is more.
You can check this one. What is Mrcpch guidance?
I did not check because once
just see this www. Just click here. It will open.
Okay, 1 minute. I will click. Clear. Mrcpch is of really sick patients with anorexia nervosa. We are multi-professional group providing guidance to clinician, assessing and managing the physical health of patients with eating disorders. It is identified a need amongst clinicians for guidance when managing adults with eating disorders. So what I will do, I will tell after doing the basic management and involving the consultant, after stabilizing the patient, I will connect with this group. I have to tell that. And I will, this group, what is the group here? They contains, as they are mentioned, pediatrician, a nurse, a psychiatrist, and a dietitian. These are the four main. See, we are a group of specialist doctors, nurses, and dietitians, all with expertise in managing eating disorders in adults, children, and young people. We are growing list of members. So I just remembered only that much. I think if I tell that much, it's more than enough. And I should know about refeeding syndrome.
Mrcpch group is dietitian.
Dietitian, pediatrician, psychiatrist, and a nurse. Here it's written, you see, including psychiatrist, nurse, dietitian, and pediatrician. Okay, if that is multidisciplinary team you will involve, but they may ask us mainly about this refeeding syndrome.
Okay.
Where in the refeeding syndrome, what I forgot to tell you was I told only about phosphate. I forgot about thiamine. We have to thiamine replacement, and also we want to give this vitamin B co-strong tablets. This I forgot. Thiamine and three
Give
things we have to. Three things we
give
have to
phosphate,
replace.
thiamine. What else?
See, three things we have to replace in refeeding syndrome. Remember like that. Three things. Phosphate is very important. If phosphate levels falls, you will give phosphate. And then thiamine, oral thiamine. Okay. And then vitamin B co-strong tablets. I just went and saw it's like because these children are not eating, they are starving usually. See what happens, this refeeding will not happen with everyone. It will happen mostly with the starving children. A switch to carbohydrate metabolism after starvation can cause acute phosphate depletion. And also all these things are not just acute phosphate depletion. There can be thiamine deficiency, hypomagnesemia, hypokalemia, and water retention. When it happens after a period of starvation, if you start taking carbohydrates,
so they will develop edema also, this extracellular water.
Yeah, they can develop edema also. So you will consider replacement of three things here. One is the phosphate, another one is the oral thiamine, and vitamin B co-strong tablets. Okay, no need for doses, just remember that much. Okay, who are at higher risk of developing refeeding syndrome? This is who are at risk. How I remember is previous history of refeeding syndrome. She should have past history. Okay, minimal energy take pre-admission means she was starving. She was taking very minimal energy means she was almost starving for a long time. Okay, this is one thing. And if they have neutropenia and BMI less than 70% of the median. I told you in the definition, I think it was 80%. I will recheck whether I told correct or wrong. Okay, typically less than 85% of the median BMI for age and gender. This is the definition of anorexia nervosa. Okay.
85% then the.
Yeah, see, restriction of energy intake relative to requirements leading to low body weight. But you have to tell that your intake, your expenditure is more than intake here. Okay.
Yeah.
Energy intake relative to requirements is restricted. That means you are doing you are not taking sufficient, you are doing more expenditure than taking it. So this is leading to low body weight, and it should be typically less than 80% of the median age for age and gender.
Okay.
So I think simple to remember refeeding syndrome. Just remember all this will be hypo. Apart from phosphate, magnesium and potassium will be hypo, and there can be edema and thiamine deficiency. So we will concentrate on replacement of the phosphate and also other means magnesium and potassium based on our lab results. And other thing we have to replace is the thiamine and vitamin B co-strong tablets. I think if we remember these 3 points about refeeding, we will complete it. Because all these too many lines is for the doses, you know, this is for the doses. I think I will not go into it, otherwise I will forget.
Okay,
that's all. Okay, so good revision of anorexia nervosa. Okay, is it okay now for you? I think we have one case now left.
This is
yesterday, you know, I did not do
coincidence. I have studied this.
Dr. Yasser, you can give your. Hello? Your mic is mute.